Hello, everyone, and thank you for joining us today. Welcome to the American Medical Association's Private Practice Simple Solutions, part of the Steps Forward Innovation Academy. Before we get started with the content, a quick few housekeeping items. The Private Practice Simple Solutions program is a series of rapid learning cycles designed to provide opportunities to implement actionable changes that can immediately increase efficiency. Please note that this presentation is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. Please take a moment to carefully review this notice. I'd like to now introduce our speakers, Dr. Brian Batson, Chief Executive Officer at Hattiesburg Clinic, and Dr. Kevin Hopkins, our moderator, Primary Care Medical Director at Cleveland Clinic. Dr. Hopkins, please take it away.
Thank you, Sumbal. Appreciate it. And thank you for joining us. To our audience, Brian, Dr. Batson, great to see you again. And thank you for joining us for this Q&A for follow-up to your webinar. Appreciate it.
Good morning, Dr. Hopkins. Good to see you as well.
Oh, thank you very much. Well, let's start. We're happy to take live questions. If you go down to the bottom right of your screen and open the Q&A window, you can enter questions that we can ask and discuss during our webinar today. But maybe we'll start while we're waiting for some questions to pop in there, Dr. Batson, with a couple of questions that were from the discussion board. And I know you answered these, but maybe if you wouldn't mind sort of giving us a summary of your answer and your thoughts on them. So thinking about value-based care, we all know that there's some risk associated with that. Sometimes it's downside risk, upside risk, or a combination of. This question was specific about medication or drug spend. So when you're in a value-based care world, what kind of risk do you take on with drug spend as far as like purchasing and billing for those? What's the contracting look like? And do you build a formulary that is unique to you and your service, or do you sort of passively take on somebody else's pharmacy benefit?
Sure. This one was a very sophisticated question, and one that I think is really important as we look at value-based care, whether you're in a large multi-specialty organization or a small independent organization that's moving into value-based care. For us, and the answer for us was highly variable depending on contracts. Of course, with the Medicare ACO contracts, those are total cost of care and include drug spend. And so in entering into those relationships, it's really important to have an understanding of what your medication cost is in your organization. You may not have that going into these relationships, but one of the benefits in being in a Medicare ACO is getting that transparency around the data, the total cost of care, and the granularity around that data. So it is definitely a place and a space that you need to be mindful of as you enter value-based care. So that's on the Medicare ACO side. On the Medicare Advantage side and the commercial side, it's really going to be dependent on the relationship, on the contract, on the specific entity with whom you're working, and what your contract is around that value-based care model that you're working on with them. The larger Medicare Advantage payers have different approaches. We've found that experience in the multiple MA partners we've had, that each of them can approach this question in a slightly different fashion on how much of that drug spend we are held responsible for, and maybe how much we're not. I think what we know absolutely to be true, what is not variable, is that this is something that is going to need to be an increased focus as we move forward in value-based care. I think CMS recognizes that, the payers recognize that as we see some really high-cost drugs enter the market and get used more in our clinical practices, how is that going to affect our ability to reduce the total cost of care? So a really important question, and I wish there was one specific answer, but there's really not. I think it's going to depend on which relationship you're in with which payer, But at the end of the day, I think it's one of the benefits of being in value-based care is you get some insight into your practice patterns. Now, your approach when you find out that information can be variable as well. So, using formularies, having your own internal formulary, and using the payer formulary are all also within the realm of possibilities.
Great. Thank you. And thinking about some of those high cost medications, even in terms of routine vaccines, I know in my practice, the Prevnar 20 vaccine for 2023, our actual cost was double what we had budgeted for it, which then obviously throws off everything that falls to the bottom line. And so, having conversations around, well, which of these vaccines, shingles is another one, are we going to continue to stock in our offices versus just, sending our patients to the pharmacy to get it done, especially those Medicare folks?
Yes, great example. We had that same experience, and then when you have vaccines that may not be covered specifically by a plan as a preventative service, it gets even more complicated. So the patient education that goes around that, and being fully transparent with the patients around how much they may have individual expense related to those.
Yes, absolutely. Okay, thank you. So I have not seen any questions come into the chat box yet, so we'll continue to watch for those. So please feel free to type away in the Q&A box. But the other question that was from the discussion board, Dr. Batson, what ideas do you have for integrating CHWs, if you could remind us what those are, CHWs into value-based healthcare and particularly reimbursement of that care?
Yeah, another great question, and one I'm glad was posed, because it had me do some more homework in this area. We talked a lot about in the presentation the building blocks on value-based care, starting with fee-for-service activities that support population health, like annual wellness visits and chronic care management, or CCM, and PCM, principal care management, and TCM, transitional care management. We talked about those. We did not talk about the new codes that CMS introduced for this calendar year in the fee schedule that were around community health integration into population health initiatives. So there are some new codes that were introduced, G codes, specifically for community health workers, CHWs, those community health workers that many of us may have in our areas, that are able to really go into the homes and assess a patient's need and provide more local support to our patients who may have unique needs. So these new codes were really exciting to see come out as ways to incorporate community health workers as part of the care team. We talked a lot about how growing the care team is crucial for population health. And our approach at Hattiesburg Clinic was to leverage the skills of registered nurses and social workers in these different programs. But these new codes also allow for community health workers. So G0019 is one of those codes. And I would encourage the audience to look into that. It's an exciting door that we are exploring for our organization as well.
Yeah, great. So you mentioned total cost of care. I mean, that's what it's all about, and trying to decrease the total healthcare spend. One of the questions I see in the Q&A, so are high spending physicians likely to get pushed out of ACOs, or physicians who tend to have a higher total cost of care for the care that they deliver because we're looking for value? Is that a risk?
Yeah, I mean, it's a fascinating idea and concept, and I think what we've seen internally is that as we get that data and are able to analyze it, many of our physicians were not aware of their practice patterns on the quality or cost side. So that transparency around the data is first important. Likewise, I think this is not a new concept in the Medicare ACO. It's not a new concept in value-based care delivery that high performers will be rewarded proportionately differently from those lower performers. That was the same phenomenon that happened in prior programs, including MIPS, most recently MIPS, that most physicians participated in, where those lower performers did not receive the fee schedule or reimbursement bumps that those high performers did. So certainly as CMS envisions a time and place where all Medicare beneficiaries are in some type of value-based arrangement with a target year of 2030, it does make us really take pause and recognize that there's a lot of work that still is yet to be done. That's a short 6 years. And for those who are not as far on that journey and don't have as many of the building blocks in place, I think that's why webinars like this and the education that the AMA and other organizations are doing are crucial, because ultimately we all want to be high performers for our patients that we're serving. But in these models, there are opportunities to start in almost every one of these examples. There are opportunities to start in upside only environments while you learn the landscape. And I certainly would encourage those who are not as far down the journey as other organizations might be to start slow. Start with those upside only arrangements, start with the basic quality measures, start with the cost measuring that you're not penalized too much. But I think the reality is that we are facing a time where the high performers are going to, as they have in MIPS, be rewarded more than those who do not perform as highly.
Mm-hmm. Yeah. And we're so used to hearing about value as sort of the future currency and panel size and all of that of value-based care going forward. And so thinking about how you define value, and that may be different based on, right? We know that it's some quality and patient outcomes divided by cost times some other multiplier, whether it's patient experience or something else. How do you define value in patient care?
Well, I think that equation is certainly one way, and I think it's a reasonable illustration of how we're defining value. But I think it goes beyond that. I think it is really more about when we're looking at populations of patients that we're serving. That while every patient that we're seeing in the exam room is the most important person at that time, as it should be, value also looks at the populations that we're serving. And I think value to me also means making sure that patient has access to resources outside me as their physician. Those are part of that care team. And I think, it ties back a little bit to some of these comments that we've had around leveraging the fee-for-service levers that are in place as you're making the transition to value. Value doesn't mean that you're ignoring fee-for-service opportunities, because those are truly helpful on this journey. And many of those levers, many of those opportunities are there to help provide a greater experience for the patient, not just in the exam room, but outside of the exam room, so that their outcomes are ultimately better.
Right. Yeah. And I often hear people say we've done a really good job of taking care of the patients who come see us, and we're also responsible for the patients who don't or who haven't come to see us. So we're getting into more and more of targeted proactive outreach for this defined population of patients, and that's harder, right, to engage those patients who maybe haven't come in to see us regularly. A couple related. Oh, go ahead.
Yeah, I'll add there. I agree completely with your comment, and I think and I've heard it said many times in many different ways, but it's retraining our minds and our brains on how we're caring for our patients. That we're trained in medical school and residency to take care of the sick patients. That is how we're trained. We're reimbursed that way in a fee-for-service model. That's how we've been reimbursed for a long time. And really reframing that mindset on being reimbursed to keep people well instead of being reimbursed to treat their sickness. And as you said, thinking about, instead of who are my patients on my schedule today, who's not on my schedule but should be, and what opportunities am I missing to take care of those?
Mhm. And thinking about the shift in payment model, we've heard phrases like value-based care, value-based contracts, pay for performance, which we've heard of for years. Is there any requirement or even uh, utility in closing to the patients that our payment model has changed? Like, is there a conflict of interest between physician and patient when we think about how this payment model has shifted?
Well, in the Medicare ACO, we must inform patients that we are participating. They do have the ability to opt out of that. I'll say from a personal experience, for me, as I've had conversations with my patients over the last several years about this journey that we've been on as an organization, they're interested in learning about it. They've either heard about it or seen about it in a flyer, or maybe in that disclosure statement that we must let them know that we're participants in a Medicare ACO. The conversations are different with patients, and I explain it similarly to how I just referenced. That our focus is really to try to keep you well instead of focusing on your illnesses, that we're dealing with endpoints that are a little bit different, and trying to be upstream with disease process. So yes, I believe it's part of the conversation with patients. I think it engages them a little bit on a different level on how our offices are operating differently than they used to, and how there are new members of our care teams that they may not necessarily see. They may only talk to on the phone once a month, but it's a different paradigm of how we're caring for them, and I believe engaging them in that understanding is crucial.
Yeah. So switching topics a little bit, but sort of in the same vein as far as thinking about total cost of care. I'm a primary care physician. I'm a family medicine physician, and I'm sure that I'm the only person on this webinar that ever does this, but once in a while, I just don't have enough time in my office visits to address everything that the patient might bring up. And it might decrease my threshold to refer to a specialty colleague for, say, a knee pain or something, when I could definitely assess it in the office if I had enough time. Given the total cost of care is such an issue and opportunity here, how do we think about the potential to decrease referrals to specialty departments in a value-based care model?
Yeah, we've all been in that situation, I think, at least once or twice in our careers, and it is one that is really important as we talk about total cost of care and value-based care. Now, I'll give a little context. Hattiesburg Clinic, we are a multi-specialty organization, so as you are, and we have, in fact, our organization, only about a third of our physicians are primary care physicians, and that number is increasing. We've intentionally increased that over the last several years, and for part of the strategy around value-based care. But if you are in a multi-specialty organization, I think it's important to be very out in front of the specialty conversation with the specialists and engage them in that journey too. We spent a lot of time in the early years of our value-based care journey in talking with our specialists and meeting with our specialists and showing them their role in value-based care. So in those situations where they may receive a referral that might not be the one that they were expecting, or one that they would accuse us as the primary care physician of maybe taking a little shortcut there, to recognize that there's a role that they have to play in this bigger picture of value-based care. It's things beyond the referral though. When you think in our organization, about half of our patients that were first attributed to our ACO had never seen a primary care physician in in our organization. So they were attributed to us because of their specialty care. So we knew from the outset that we needed to have a specialty focus on value-based care, because those patients, while we were needing to get them into primary care, they were still getting their blood pressure done, and that was a quality measure. And they were still getting a depression screen done or not in a specialty office, and all these other quality measures that were important for us to socialize throughout the organization and show the specialist their role. We were very clear that we were not asking, specialist X to treat hypertension if the patient was referred to them for knee pain. However, we showed them that their role was to check the blood pressure correctly, and if the blood pressure was high, to make sure that patient was getting follow-up care at a treating physician's office. So there was a little bit of a give and a take with this. Now, on the flip side, as we engaged the specialist in the conversation, we also made it very clear that if we were successful in value-based care, they would benefit from that from a financial standpoint. So we took the approach that we are in this together as an organization, all of us, regardless of the specialty on your white coat, that you are a part of this value-based care journey in our organization, and we're going to succeed together or we're going to fail together. And to that end, I think it helped us really approach it from a collaborative fashion, and share in those successes with each other. Back to the referral question, I think it does shed some light on referral patterns, and we needed to increase some transparency around that, which we have done, and I think is important in the organization, because we all have a highly variable panel in the complexity of the patients, the sickness of those patients, and some of those are going to need more referrals. So we've begun having some conversations around, what is the right number of visits that a patient should have with their PCP versus how many specialist visits they have per year. And maybe there is a magic number out there. I don't know what it is yet, but we're certainly having those conversations about making sure that the referrals that are placed are really appropriate referrals.
So thinking about that, that critical cooperation for mutual success between primary care and non-primary care specialists, I'd love to unpack that a little bit more with you. When we first started talking about value-based care, sort of the pervasive attitude was, well, that's sort of a primary care problem, and certainly that has changed and shifted. So what would you say are some of the latest developments in how non-primary care specialists are included and engaged in value-based care arrangements, and how's that done at Hattiesburg? I heard you say, especially, we all succeed together, or we don't succeed together. Things like checking blood pressure and encouraging follow-up. Any other specifics that you've seen as far as developments in integrating our specialty provider colleagues in with this value-based care?
Sure. CMS has in the innovations model has continued to release specialty bundles. Some of those which are mandatory, some are voluntary. So those are really targeted in oncology and orthopedics and other areas. Those continue to emerge, and we're seeing a lot more activity in that space in the commercial area, at least in our part of the country, and in the Medicare Advantage space. So those are really, really targeted areas. But I would say beyond those targeted areas, Medicare, through the ACO, we're getting what are called shadow bundles now as part of our data set that we get back from CMS, so that we're able to look at that very, very specific cost and quality data around some very specific disease processes, such as joint replacement or heart surgeries or things like that. So there continues to be increased attention in these spaces, and also I think appropriately and thankfully, that there's more data that's being shared with us as the organization who is responsible for the multi-specialty care. Now, there is specialty care that occurs outside of Hattiesburg Clinic, so we have that visibility as well. So we know when our patients in these plans are seeking care outside of our organization, we have a full picture of the cost of care in those facilities and in those offices and with those physicians who aren't a part of our organization as well. So it's both an internal conversation, but also an outward looking conversation to the specialists with whom we work.
And thinking about those referrals, how should we sort of close the loop on specialty referrals? So those patients who we refer to maybe a specialty partner or colleague, how do we ensure that that referral is meeting the patient's needs? How do we make sure, first of all, that they even went or engaged with that appointment? And what's our responsibility in a value-based contract world with that?
Yeah, that's a tough one, but a really important question too. I think as infrastructure needs emerged with our value-based care growth, this is a space that we recognize that we needed some dedicated resources as well to close the referral loop and to make sure that those patients who are being referred, quote unquote, outside our organization are getting the care they need. And then, as you point out, making sure that it's the care that they really wanted and that we want as their primary care physicians who are ultimately responsible for their value-based care delivery. So it's a little bit nuanced and complicated, but I think there are infrastructure needs. Whether your EMR can track that or not, we struggle with some of those external referrals as well. But having a system in place so that you can track those and then follow them through with those patients who leave your system for those specialty referrals is a crucial piece of this, certainly.
It was so interesting to hear you say, Dr. Batson, a moment ago, that I think you said like 50% of the patients within your system had not seen a primary care physician. And so even thinking about that opportunity for partnership, because we've seen the same. I work at a high-end specialty, multi-specialty group, and we have a lot of patients that we see that either don't have a PCP or don't have a PCP within our system. How can our specialty practices help with getting patients linked up with primary care?
Yeah, great. This was really one of those eye-opening moments for us when we entered into that value-based contract and got that first attribution list, those patients who were assigned to us, and they're assigned to us based on prior visit behavior. And through CMS's attribution model, if they're not seeing a PCP, then they are assigned to a specialist through a stepwise attribution model. It was, as I said, one of those kind of eye-opening moments for us that we as a multi-specialty organization had a lot of patients who weren't yet plugged in with a PCP. We saw that as an opportunity. We saw it as an opportunity to increase the stickiness to our organization by getting them aligned with a PCP that's local to them. So our specialty, geographically, our specialty clinic is really centrally located, but we have a lot of outlying primary care clinics, and we wanted those patients to have local care as well. So we saw it as a way to increase the stickiness with the organization, but also really to improve the care delivery that those patients were receiving, so that we could focus on preventative services, focus on better blood pressure control and diabetic control, and not just focus on their specialty care, which is how they ended up with our organization in the first place, which was a nice refresh as a primary care physician. Of course, that was a nice way for us to evolve as an organization to look at the patient more holistically.
Yeah, we're so used to hearing about primary care feeding specialty care, and it is nice to see and realize, even in the data, that door does go both ways. And like you said earlier, we either succeed together or we don't succeed together. So we're getting close to time. So a couple more questions to wrap us up. And this has been great because we've had a lot of incoming questions, which is really cool. So this is something that that I know a lot of places struggle with. We talked about being responsible not only for the patients who are coming to see us, but for those who don't. What have you heard as far as most effective means or methods of outreach to patients? I think when my phone rings, if I don't know who's calling, I don't answer it. And getting patients to respond to patient portal messages is a challenge, those types of things. Is there anything that you've seen that's worked, or what have you tried?
We've the mixed bag that we all are trying to figure out what is the unique set. I think the lessons that we have learned is that it's not one thing. It really is a combination of multiple things, whether it be those things that you mentioned, whether it be even a letter, a letter to someone's home is sometimes the one thing that patients will respond to. I think one of the keys to our success in the CCM, chronic care management platform, when we were doing outreach to our patients who were signed up in that program, is we embedded those case manager RNs in the PCP's offices. So those case managers, when the caller ID came across, it came across as, Dr. Batson's office, Hattiesburg Clinic. It didn't come across from a number they didn't recognize. I think that increased engagement, increased awareness, and it also, I think, improved with the trust in the program and increased the trust, because truly those case managers are right down the hall. Even though they may not have laid eyes on those case managers before, we try to get them to introduce themselves when they're in the office. But little things like that, the outreach phone calls, of course, the patient messages. For those patients who've opted in to text messaging through the EMR, that is the way that some people prefer to engage with us as their healthcare providers. So keeping all those options on the table, I think, is a crucial way to make sure you're capturing as many people as possible.
Okay. Are you able to point out what was maybe the biggest pain point to implementing a value-based care model at Hattiesburg?
Well, I think the biggest pain point was really the first educational waves that we did throughout the organization. This was a big step for us, as it is for many organizations. We're a 60-year-old organization and had focused in fee-for-service for the majority of that time. So I would say the hardest part was getting started. And that required, us educating ourselves first, and then figuring out what resources we had and what resources we needed to bring in-house, and which ones that we probably weren't going to be able to bring in-house, and find partners to do that. So getting started, I think, was the hardest part. Maybe not, and I would say pain. Yeah, sure, pain point was getting out of the gates. And while we weren't able to convince all 300 physician partners that this was the correct path to go, it just took a little bit at a time, and continuous, process improvement through time and education, and a lot of feedback and a lot of transparency with our organization, our physician, and all of our staff to show that this was the new direction that the organization was going to go. And ultimately provide better health care for those patients that we were charged with serving.
Yeah, starting with a blank sheet is always harder than starting with a rough draft. So getting started. And so the converse to that question, what's been the biggest upside? No pun pun sort of intended. What's been the biggest positive?
Well, sure. I think in those first few years, for those who saw our recorded webinar, we had a pretty grim picture when we looked in the mirror of our organization quality and cost, and to see that just absolutely change over the course of 4 or 5 years to where we knew we were providing better health care to our patients. We knew with objective data, not just that, what we tell ourselves, it was objective data that showed that we were doing better in caring for those patients under our care. And then, of course, as we evolved and did start receiving some reimbursement and shared savings, that was a nice moment to finally reach that as well.
Yeah. So you mentioned data. So I'll wrap up with this point. We've all heard the axiom, if you can't manage what you can't measure, right? So data is so important in healthcare today, but especially in the value-based care world. If we're a practice just getting started in value-based care, how do I ensure that we're looking at the right data and that it's accurate and we're getting it in a timely manner so that we can set ourselves up for success in this world?
Yeah, this is a tough one, and I think one that is crucial at the outset, so that you start to familiarize yourself very granularly with the data that you're getting, regardless of which program you're in. Because unfortunately, the different payers, the different programs give you the data in different formats, so it requires a good amount of work, and it's not that you're getting misinformation, it's just information in a different way or information you've never gotten before. So I think that's a crucial step in the beginning. And it goes back to my recommendation on starting slowly and doing it in bites that are digestible, so that when you are getting the data, you can really dig into it and understand, does this match up with what I believe is happening internally, and then validate it. I mean, it takes a lot of validation. But spending that time is crucial at the outset to make sure that you're familiarizing yourself with the data first, but then also validating against what you believe to be the truth about your organization. And if there isn't a match in that, figuring out where the discrepancy lies, because it could be that the view that we'd had of ourselves wasn't accurate, and now this is our first true glimpse into it. But really spending the time to reconcile that and make sure that you understand the data that you're getting, and then once you start to validate it and believe it, implementing programs to improve.
Yeah, people are always going to question the accuracy and validity of the data, but at the end of the day, it is what it is, and if it's what we've got, that's what we need to go off of. Brian, always a pleasure to see you and talk with you. Thank you so much. Dr. Brian Batson has been our guest for today, CEO of Hattiesburg Clinic, and thank you for your thoughts and expertise in this area. And Sambal, I'll turn it back to you to close us out.
Thank you, Dr. Hopkins. Thank you both for your time today and for the audience for such great questions. I'd encourage you, if you have any other questions, to post them on our discussion board located on the right-hand side. That way, Dr. Batson can go in and reply to any additional questions you have. That concludes our presentation for today. Thank you, everyone, for joining us. And we encourage you to check out the website here for practical tools and resources in supporting private practices. Have a great day.